Endocrine disorders in pregnancy. So welcome. So among the endocrinopathies in pregnancy, we have diabetes mellitus being the commonest, followed by thyroid disorders, but can also have pituitary, adrenal, and parathyroid disorders, which are usually less common. And since now we have a separate class on diabetes mellitus, today I'm going to measure more on the thyroid disorders because they are the second most common. But just to mention a few, on the parathyroid disorders in pregnancy, we can have hyperparathyroidism, hypoparathyroidism. We can also have pregnancy-associated osteoporosis. And then on the adrenal disorders, we can have pheochromocytoma, we can have Cushing's syndrome, we can have adrenal insufficiency, we can have primary aldosteronism, we can also have congenital adrenal hyperplasia. And now for the pituitary disorders, we can have prolactinomas, we can have acromegaly, we can also have diabetes insipidus, we can have Sheehan's syndrome. Yeah, so on to the thyroid disorders in pregnancy. I'm going to begin with a bit of anatomy of the thyroid gland. It is usually a bilobed gland on the anterior aspect of the neck. The lobes are connected by an isthmus. Each lobe measures around 4 by 2 centimeters, and they weigh around 12 to 20 grams. We can also have a third pyramidal lobe, which may project upwards. For the blood supply of the thyroid gland, we have the superior and the inferior thyroid arteries, branches of external carotid and thyrocervical trunk, respectively. So this is a pictorial presentation of the gross anatomy of the thyroid gland. You will see it clearly when you get the slides later. So for the physiology of the thyroid gland, usually we have the thyroid hormones being produced by the thyroid gland at a ratio of T4 to T3, a ratio of 10:1. That is, the gland secretes approximately 80 to 100 milligrams of T4 and 10 micrograms of T3 per day. But then we have only 10% of the circulating T3, which is derived from direct thyroid secretion. And then 90% is produced by peripheral conversion of T4 to T3. And then the T4 is converted to either the active hormone T3 or to the biologically inactive reverse T3. So in circulation, the hormones exist in both the active free and inactive protein-bound forms, with T4 being 99.98% bound and only 0.02% being free. But then for the T3, it is usually less protein bound at 99.8%. And the hormones are metabolized in the periphery, that is the kidney, liver, and the heart by deiodination. And T4 and T3 are also eliminated by biliary secretion of the glucuronide and sulfate conjugation. And then we have the half-life of T4 in the plasma being about 6 to 7 days, and that of T3 being much less, around 24 to 36 hours. So the factors which affect thyroxine binding albumin and thyroxine binding prealbumin and thyroxine binding globulin, like estrogen, viral hepatitis, nephrotic syndrome, corticosteroids, and liver failure usually alter the circulating hormone levels. So we also have the T4 to T3 conversion is usually impaired by fasting, systemic illnesses, acute trauma, medications like propionthiouracil, amiodarone, and glucocorticoids. So this is a pictorial representation of the axis between the hypothalamus, the anterior pituitary, the thyroid gland, where we have the production of the thyrotropin-releasing hormone at the hypothalamus. Then we can also have it stimulates the anterior thyroid to produce the thyroid stimulating hormone. And then now the thyroid stimulating hormone acts on the thyroid gland now to produce the thyroid hormones, that is T3 and T4. So we have the different physiologic effects of the thyroid hormones, which usually affect major systems in the body. So we have in the heart, they have inotropic and chronotropic effects, that is increase of contractile activity. They can also act on the adipose tissue, which they stimulate lipolysis. On the muscle, they increase protein breakdown. On the bone, they promote normal bone growth. On the CNS, they promote normal brain development. On the gut, they increase carbohydrate absorption. Can also have other effects like oxygen stimulation, consumption by metabolically active tissues, except testes, uterus, spleen, lymph nodes, and the anterior pituitary gland. So we have different thyroid adaptations during normal pregnancy. So now we have to meet the increased metabolic needs during normal pregnancy. There are changes in thyroid physiology that are reflected in altered thyroid function tests, and these may include an increase in serum thyroxine binding globulin, stimulation of thyrotropin receptor by human chorionic gonadotropin. We also have increase in iodine requirements. So for the thyroxine binding globulin, during pregnancy, we have serum TBG concentrations are almost twofold because estrogen increases TBG production, which results in decreased clearance of TBG. So now to maintain the adequate free thyroid hormone concentrations, we have now the thyroxine, which is T4 and T3 production by the thyroid gland must increase. So now the TBG excess leads to an increase in both serum total, but not free T4 and T3 concentrations. So for the HCG and thyroid function, we have an HCG as weak thyroid stimulating activity. So you find that serum concentrations of HCG increase soon after fertilization, and they usually peak at around 10 to 12 weeks. So during this peak, the total serum thyroid hormones concentrations usually increase. So this transient usually subclinical hyperthyroidism should be considered a normal physiologic finding. That we have serum free T4 and T3 concentrations increasing slightly, but usually within the normal range. And now the serum TSH concentration are appropriately reduced. But then later in pregnancy, as HCG levels declines, we have the serum T4 and T3 concentration declining too. And now the serum TSH concentrations now start to rise slightly. We can also have now the iodine requirements. Iodine requirements are higher in pregnant women than as compared to non-pregnant women. This is due to both the increase in maternal T4 production requirements to maintain the maternal euthyroidism and an increase in renal iodine clearance. So we have severe maternal iodine deficiency during pregnancy, which can result in a reduction in maternal T4 production, inadequate placental transfer of maternal T4, and impairment of fetal neurologic development. So now I'll go now to the specific disorders. I'll start with hyperthyroidism in pregnancy. So,
excuse me, did you tell us what the recommended daily intake of iodine in pregnancy?
Pardon?
Recommended daily intake of iodine in pregnancy.
Pardon?
Just carry on, and we'll discuss it.
Okay. So we can have overt hypothyroidism and subclinical hyperthyroidism. Usually overt hyperthyroidism is where we have a low TSH with free T4 or T3 levels that are usually that exceed trimester specific normal reference ranges, or a total T4 and T3 that exceeds 1.5 times the non-pregnant range. So these overt hyperthyroidism usually relatively uncommon during pregnancy, occurring at around 0.1 to 0.4% of all pregnancies. We can also have now the subclinical hyperthyroidism, where we have a low TSH, but now here we have the T4 and T3 being within the normal ranges. It is usually transient, and in the first trimester of pregnancy, it is considered a normal physiologic finding. So we can have now the causes of hyperthyroidism. We can have a Graves' disease, which usually occurs in 0.1 to 1% of all pregnancies. We can have now the HD-mediated hyperthyroidism. We can also have other causes like silent or subacute thyroiditis, toxic adenomas, toxic multinodular goiters, and factitious teratoxicosis, which are usually less common during pregnancy. Now for the HCG-mediated hyperthyroidism, now the gestational transient thyrotoxicosis, we have usually high serum concentrations of HCG early during pregnancy, and that can lead to a subclinical or mild overt hyperthyroidism. You can also have hyperemesis gravidarum, where we have higher serum HCG levels and estradiol concentrations in those women than normal pregnant women. And in addition, we can also have the HCG as which has more thyroid stimulating activity. You can also have trophoblastic hyperthyroidism, which are associated with high serum HCG concentrations. And then the familial gestational hyperthyroidism, where we have recurrent gestational hyperthyroidism being described in one family due to a mutant thyrotropin receptor that is hypersensitive to physiologic concentrations of HCG. We have the clinical manifestations of hyperthyroidism. We can have tachycardia, heat intolerance, and increased perspiration, anxiety, palpitations, weakness, weight loss despite a normal or increased appetite, and also specific findings such as goiter and ophthalmopathy like Graves' hyperthyroidism. You can also have the signs like hyperactivity and rapid speech, stare and lead lag, which represents sympathetic hyperactivity. The skin is typically warm and moist. The air may be thin and fine, and also we can also have tachycardia. So this is a representation of the clinical manifestations of hyperthyroidism as described before. So now for the pregnancy complications in overt hyperthyroidism, we can divide them in maternal and fetal. So for the maternal complications, this can lead to spontaneous abortions, premature labor, preeclampsia, heart failure, placental abruption, thyroid storm, and infection. And for the fetal complications, it can lead to low birth weight, stillbirth, intrauterine growth retardation, and hypo or hyperthyroidism. Now for the subclinical hyperthyroidism, there's usually no evidence of adverse pregnancy outcomes. But then we also found that there was a study that found there was a lower incidence of spontaneous abortion during the week 4 to week 8 of pregnancy, and a higher risk of preeclampsia. So for the investigations that you want to do the thyroid function tests. You want to check the levels of TSH. You also want to check the levels of T4 and T3, and for both free and total levels. We also want to do a thyroid ultrasound with Doppler flow, which may be useful to distinguish a Graves' disease, which demonstrates a high blood flow, from painless or postpartum thyroiditis, which demonstrates a low blood flow. We can also do a TSH receptor antibodies. So we have ATA guidelines for the interpretation of TFTs. So between week 7 to week 12, usually there's a you have to reduce the lower limits of the reference range of TSH by approximately 0.4 milli international units per liter, and the upper limits by 0.5 milli international units per liter. Then now for the second and third trimester, there should be a gradual return of TSH towards the non-pregnant normal range. Now the upper reference range of total TF4 increases by approximately 5% per week, beginning at week 7. Then at approximately 16 weeks, the total T4 and T3 levels during pregnancy are around 1.5-fold higher than in the non-pregnant women. This is due to TBG excess. So for the treatment of the hyperthyroidism in pregnancy, the goal is usually to maintain persistent but mild hyperthyroidism in the mother in an attempt to prevent fetal hypothyroidism, which can be a complication of the treatment, since the fetal thyroid is more sensitive to the action of antithyroid drugs. So now to attain the mild hyperthyroidism, one, the free T4 concentration should be maintained at just or above the trimester-specific normal range for pregnancy, or the total T4 and T3 should be maintained at around 1.5 times above the non-pregnant reference range. The serum TSH concentrations should be below the reference range for pregnancy. So indications.
Excuse me.
Yes.
How often are you doing this test once you start treatment?
Okay, I'll cover it later in the presentation.
Okay.
Yeah. So for the indications for treatment, one, we have women with symptomatic moderate to severe overt hyperthyroidism due to Graves' disease, toxic adenoma, toxic multinodular goiter, and also in gestational trophoblastic disease in patients require a treatment of hyperthyroidism. So you may not need.
Excuse me. So which is the commonest cause of that hyperthyroidism in pregnancy? Of all those you have talked about.
The what?
Which is the commonest cause of hyperthyroidism? Of all those reasons, the previous slide, in that slide that you talked about. Are you going to tell us what Graves' disease is later on? Or?
No.
It's Graves' disease. Huh?
Okay. Thank you. So we may not require treatment in patients with transient subclinical hyperthyroidism in the first trimester of pregnancy, or patients with HSD-mediated overt hyperthyroidism, or patients with hyperemesis gravidarum associated hyperthyroidism, or in patients with subclinical and mild asymptomatic overt hyperthyroidism due to Graves' disease, toxic adenoma, or toxic multinodular goiter. So now for the treatment options, we have thionamides, which primarily, this is the primary treatment of hyperthyroidism due to Graves' disease, toxic adenoma, or toxic multinodular goiter during pregnancy. We can also have beta blockers, which can be used to treat. Yes.
Which drugs are these you're talking about, number one? And how do they work? Because it's very critical to understand how they work and why we give them.
Yeah, they are in the next slide.
Okay. Carry on.
Okay. So we can also use the beta blockers, which can be used to treat tachycardia and tremors. And we can also do thyroidectomy, which it is rarely done during pregnancy, but it is an option for women who cannot tolerate thionamides because of allergy of or agranulocytosis. So now for the thionamides, we can have methimazole, which is preferred to propionthyrase, the uracil, except during the first trimester of pregnancy. So during the first trimester, you should prefer a propylthiouracil, which you have the initial dosing of 50 milligrams 2 to 3 times per day. You can also use now the methimazole 5 to 10 milligrams daily, or carbimazole 5 to 15 milligrams daily. However, in patients with severe hyperthyroidism, the full doses of PTU, which are usually 100 milligrams 3 times per day, or methimazole 10 to 30 milligrams daily, may be required to control hyperthyroidism. And patients may continue with PTU for the remainder of pregnancy or switch back to methimazole at 16 weeks of pregnancy.
Why? Allow me to ask, just go back. So how do these two drugs work? What do they target?
For the PTU, okay, it inhibits the production of new thyroid hormone in the thyroid gland, and it can also act by inhibiting the enzyme thyroid peroxidase, which usually functions to convert iodine to iodine molecules.
Okay, carry on.
So now for the adverse effects of thionamides, they have been associated with possible teratogenic effects, but the teratogenic effects are more severe with methimazole and carbimazole compared to PTU. And these include aplasia cutis, tracheoesophageal fistulas, choanoatrasias, omphalocele, and omphalomesenteric duct anomaly in methimazole and carbimazole. But for the PTU, it is associated with liver failure, and hence methimazole is preferred in nursing mothers. So prior to
what's the difference between methimazole and carbimazole? The others can answer as well. What's the difference?
So I think for carbimazole it's a prodrug that is converted to active metabolite. I think for carbimazole it's a prodrug. For the methimazole, not so sure.
So is methimazole the prodrug or it's carbimazole? Endelea tu daktari.
Okay. So prior to initiation of thionamides, you want to do CBCs with differentiation with WBC differentiation. We also want to do a liver profile where you check for the bilirubin and transaminases. But then for the thionamides, they are contraindicated where you have an absolute neutrophil count of less than 1,000 cells per molecular, and where we have increased transaminases of around more than 5-fold of the normal level. So for the beta blockers that you can use in hyperthyroidism, you can use metoprolol around 25 to 50 milligrams daily, or propranolol 20 milligrams 3 to 4 times daily. But then now for the long-term treatment with beta blockers, which is usually around longer than 2 to 6 weeks, we should avoid in pregnant women because of concerns of neonatal growth restriction, hypoglycemia, respiratory distress, and bradycardia, especially with atenolol. So for the monitoring, the thyroid function tests should be obtained every 4 weeks throughout pregnancy for dose adjustment. But if now the thionamides are discontinued in early pregnancy, thyroid tests should be checked weekly throughout the first trimester, then monthly. And now for the women diagnosed with hyperthyroidism during pregnancy, who will be taking thionamides, serum thyrotropin antibodies, thyrotropin receptor antibodies should be measured at diagnosis. And if they are elevated, again at 18 to 22 weeks, and then at 30 to 34 weeks of gestation. So for the dosage to be, yes.
Sorry, carry on.
So for the dosage to be adjusted to maintain a total of T4 of at around 1.5 times upper limit of normal. So you do the TFTs every 2 to 4 weeks, LFTs every 3 to 4 weeks, and then the CBC to assess the transient leukopenia and agranulocytosis that is caused by the methimazole. So let's now go to the fetal or neonatal hyperthyroidism, which is usually seen in approximately 1 to 5% of mothers with hyperthyroidism caused by Graves' disease. And then they usually present with high fetal heart rate of around more than 160 beats per minute, fetal goiter, advanced bone age, poor growth, and craniosynostosis. And then they can also have cardiac failure and hydrops, which may occur in severe disease. So measurement of maternal serum thyrotropin receptor antibodies during the 3rd trimester helps to predict which infants are at a higher risk for development of fetal and neonatal Graves' hyperthyroidism. And the fetus or infant is more likely to have a Graves' hyperthyroidism when the maternal value is more than 3 to 5 times the upper limit of the normal. So all fetuses with Graves, of women with Graves' disease should be monitored for signs of fetal teratoxicosis by checking the fetal heart rate, the fetal growth rate, and doing a fetal thyroid ultrasound. And thionamides may be given to the mothers regardless of maternal thyroid status to treat the hyperthyroid fetus. But then if maternal hyperthyroidism develops as a complication of the treatment, she should be treated with levothyroxine. We can also have a thyroid storm.
Can the fetus instead develop neonatal or fetal hypothyroidism in a mother with Graves'? If yes, how? If no, why?
I'm not so sure of that, doctor.
Okay, carry on. Someone will answer at the end. one of you.
Okay. We can also have a thyroid storm during pregnancy, usually a medical emergency. It is diagnosed by features of severe teratoxicosis, like hyperpyrexia of 39 degrees Celsius, tachycardia of more than 140 beats per minute. They can also present with congestive cardiac failure and neuropsychiatric symptoms. Then it can be precipitated by preeclampsia, anemia, and sepsis during pregnancy. And lab tests usually show hyperthyroid changes. So now for the management of the thyroid storm in pregnancy, you have first of all it's a medical emergency. So usually it is done in the ICU. So you have to do the supportive therapy in the ICU, where you can give fluids and electrolytes, and then oxygen therapy and acetaminophen for the hyperpyrexia. So now you can also manage the CCF. There is a role for beta blockers to control hyperdynamic symptoms. You can now give the antithyroid drugs. You can give the PTU or methimazole to block thyroid hormone synthesis.
Before you carry on,
okay.
Why do we not give methimazole for a thyroid storm, but prefer propylthiouracil? Actually, there is almost no role for methimazole in thyroid storm.
Okay.
Why? So the first drug should actually be a PTU, because the beta blockers are just for controlling the heart rate and such things. But remember, you need to control, or sort of to have control of the T3, T4 that are causing the symptoms that you see. So why? The answer is in what's the difference in the mechanism of action between PTU and methimazole? How do they work? As someone will tell us at the end. Then I hope there's also a slide on what are some of the things that can precipitate thyroid storm in pregnant women.
Okay.
We continue.
There is also you can also give now the iodine compounds. You can give Lugol's iodine solution. You can give it orally, or you can give it via NG tube, usually to block the release of the thyroid hormones. You can give it at least 1 hour after starting the antithyroid drugs therapy. Usually it is given around 10 drops every 8 hours. I can also give now the glucocorticoids to block the peripheral conversion of serum T4 to T3. Yep. So we can also have gestational teratoxicosis, usually called transient hyperthyroidism, and it is associated with hyperemesis gravidarum, where we have high serum levels of thyroxine and low serum levels of TSH, but usually have high beta HCG levels, which is structurally similar to TSH. And now the gestational trophoblastic disease can also present with hyperthyroidism. So patients with hyperemesis should be evaluated for T4, TSH, and now the erotropin receptor antibodies. Usually the antithyroid drugs are not indicated here, but now we have the role of beta blockers for the peripheral manifestations. But you can give antithyroid drugs if the Graves' disease is diagnosed, where we have the free T4 levels being more than 1.5 times the upper normal limit, or where we have now the TSH levels being less than 0.01 microinternational units per milliliter.
Can I come in? That is why it is very critical to understand those changes that happen in pregnancy, the TBG, TSH, and the other thyroid hormones. And the fact that the important hormone that you're looking for and assessing in terms of treatment is the free hormone, not the total. Okay. Then I agree with you, antithyroid drugs are not indicated. But the big question is, does this affect pregnancy adversely or not? Yes or no? Does it adversely affect pregnancy or not?
I'm not sure.
So if you're not treating it, obviously, probably it's not affecting pregnancy adversely. So you don't need to treat it. Most of the time, it self-resolves once the HCG tapers down and goes back to within the normal limits. So once you evacuate a GTN or a GTB.
Okay.
Carry on.
So I would like us to go to hypothyroidism. And before I go there, I have a small case here. So we have this lady, 28-year-old, presenting 2 months postpartum with anxiety, insomnia, and palpitations. She's had a normal pregnancy and a healthy baby. But then the lady attributes the symptoms to having a new baby. So for the family history, she has a brother with hypothyroidism. On examination, we find her with BPs of 112 out of 68 millimeters of mercury, the heart rate of 104, with fine tremors and a clammy skin. Thyroid exam is normal. Now the labs show that she has a TSH of 0.01 milli international units per liter. Yeah, so with that in mind, let me now go to the hypothyroidism as we ponder on it. So we can have overt hypothyroidism and subclinical hypothyroidism, where we have now the overt being we have elevated population and trimester-specific TSH concentration in conjunction with decreased free T4 concentration. Usually, so like we have high TSH and low T4. For the subclinical one, we have high TSH and normal T4. So for the causes of hypothyroidism, we have iodine deficiency, can have autoimmune hypothyroidism, maternal thyroidectomy, you can also have a hypothyroidism treatment. So for the features, they can present with fatigue, cold intolerance, constipation, weight gain. For the pregnancy complications, usually may lead to preeclampsia and gestational hypertension, placental abruption, non-reassuring fetal heart rate, preterm delivery, including a very preterm delivery, that is before 32 weeks of age. We have a low birth weight, increased rate of cesarean sections, perinatal morbidity and mortality. Can also have neuropsychological and cognitive impairments in the child. For the investigations, when you do your TSH, you'll find elevated population and trimester-specific TSH concentration above 4.0 milli international units per liter. But now for the free thyroxine, usually decreased concentration below SA normal using reference range for pregnant women. For the thyroid peroxidase antibodies in pregnant women with TSH, they're usually more than 2.5 milli international units per liter. For the treatment, usually the treatment of choice is giving synthetic levothyroxine, that is T4. But now this one depends on the levels of TSH. So where we have TSH being more than 4 milli international units per liter, with low free T4, usually you give a full replacement dose, that is approximately around 1.6 micrograms per kg body weight per day. But now if we have a TSH being less than 4 milli international units per liter with normal free T4, you can give an intermediate dose of around 1 micrograms per kg per day. And now when we have a TSH of 2.6 to 4 milli international units per liter, if a decision has been made to treat your thyroid human with TPO antibodies, usually give a low dose, typically around 50 micrograms daily. So T4 should not be taken on an empty stomach. Ideally, you should give it an hour before breakfast. But few patients are able to wait a full hour. This is because usually food or usually when you take it with food, it impairs its absorption in the gut. So it is usually advised to take on an empty stomach. So for the monitoring, after initiation of T4 therapy, the patient should be reevaluated and the serum TSH levels measured in 4 weeks. Here, the goal is to maintain TSH in the lower half of trimester. So for the screening, it is not routinely done during the first trimester, but it can be done in certain patients, including patients living in an area of moderate to severe iodine insufficiency, patients with symptoms of hypothyroidism, and patients with family or personal history of thyroid disease. You can also have in patients with a personal history of thyroid peroxidase antibodies, goiter, patients aged 30 years and above, patients with type 1 diabetes, patients who has had head and neck radiation, patients with recurrent miscarriage or preterm delivery, patients who had overhad multiple prior pregnancies, that is 2 or more, patients who are infertile, patients with prior thyroid surgery, and patients who have been using amiodarone, lithium, or recent administration of iodinated radiologic contrast agents. So I would like us to go to the postpartum thyroid dysfunction.
Before you go as well.
Yes. Yes.
Did you speak of the adverse outcomes of that hypothyroidism?
No.
Adverse pregnancy outcomes.
Adverse?
Pregnancy outcomes of overt hypothyroidism.
No.
How does it adversely affect pregnancy? Okay. Second question.
Yes.
What is the commonest cause of overt hypothyroidism? Well, let me begin by asking, what are the TPO antibodies you are speaking about?
So we can have
Okay, just ponder on these questions, you and the rest of the classmates. Then, did you tell us of the incidence of what hypothyroidism?
Okay.
Then the other question is, are there adverse fetal and neonatal effects of overt hypothyroidism? Will the fetus be affected? That's the question I'm trying to ask.
Okay.
Then also you spoke about treatment. I think we agreed every 4 to 6 weeks with you spoke of target TSH level. That is okay. But the other question is, will the requirements of this levothyroxine supplementation increase in pregnancy or not? Okay. Then the other question, I hope someone is going to answer this question. Then the last question, did you speak about subclinical hypothyroidism?
No.
What is it? Does it adversely affect pregnancy? Do we need to treat it? Okay, carry on.
So for the postpartum thyroid dysfunction, we have postpartum thyroiditis. It is usually a destructive thyroiditis induced by an autoimmune mechanism within a year past parturition, but it can also occur after spontaneous over-induced abortion, usually considered a variant of Hashimoto's thyroiditis, and presents with one of the following ways: transient hypothyroidism alone at around 20 to 40% cases, transient hypothyroidism alone around 40 to 50%, and then transient hypothyroidism followed by hypothyroidism, and then recovery around 20 to 30% cases. So the prevalence usually varies globally and ranges from 1 to 17%. We have rates of around 25% being reported in women with type 1 DM, and the highest rates occur among women with prior history of postpartum thyroiditis and positive antithyroid peroxidase antibody titers. And then 20 to 30% of women with postpartum thyroiditis have the characteristic sequence of hypothyroidism, which usually begins 1 to 4 months after delivery, and then lasts to 2 to 8 weeks, then followed by hypothyroidism, which also lasts approximately 2 to 6 weeks, and then recovery.
Why? Why do you have such a picture? Hyper, then finally having hypo. Okay, carry on.
So for the investigations, you do the levels of TSH and the levels of T4. But then for the women presenting with postpartum hypothyroidism, assessment of antithyroid peroxidase antibodies can help in confirming postpartum thyroiditis and also to predict the future course of the disease. For the treatment, most women with postpartum thyroiditis usually present with mild symptoms during the hyperthyroid phase, and they usually do not require any treatment. Then they should have a repeat thyroid tests in 4 to 8 weeks to confirm a resolution of the hyperthyroidism. But we have a role of beta blockers, which may be used to relieve palpitations or other tremulousness in symptomatic women. During the hypothyroid phase of postpartum thyroiditis, symptomatic women with increased levels of TSH and above the normal range, they can usually require levothyroxine. For the asymptomatic ones, with a TSH level of more than 10 milli-international units per liter, we also suggest T4 replacement. So most women usually recover and are euthyroid within 1 year postpartum. So we typically continue thyroid hormones for around 6 to 12 months before attempting withdrawal, unless the woman is pregnant, attempting pregnancy, or she's breastfeeding. But now the thyroid hormone can be completely stopped with assessment of thyroid function tests 6 weeks later. So up to 30% women usually never recover from the initial hypothyroid phase, and they usually progress to have a permanent hypothyroidism. For the monitoring part, women with reversible hypothyroidism are also at increased risk for developing permanent hypothyroidism in future, and therefore they usually require yearly monitoring of TSH levels. So for the Graves' disease, it's usually a syndrome that may consist of hyperthyroidism, goiter, orbitopathy, and occasionally a dermopathy, which is usually referred to as pretibial or localized myxedema. And women may develop Graves' disease postpartum, or can also experience it on exacerbation. So in addition, women with remission after antithyroid drug therapy have a higher incidence of relapse during postpartum. So now we have a comparison between the Graves' disease and postpartum thyroiditis. So for the onset, usually for the Graves' disease, 6 months post-delivery. For the postpartum thyroiditis, within 3 months of delivery. For the presentation, the Graves' disease is usually more symptomatic compared to the postpartum thyroiditis. So we have more thyroid enlargement in Graves' disease and may have ophthalmopathy or pretibial myxedema. Now for the postpartum thyroiditis, usually the symptoms are mild. The enlargement of the thyroid gland is usually minimal, and the Graves' ophthalmopathy is usually absent. For the hormones in Graves' disease, usually have a high T3 to T4 ratio. But now for the postpartum thyroiditis, we have high T4 levels compared to T3. And now for the thyrotropin receptor antibodies levels, usually elevated in Graves' disease, but they are normal in postpartum thyroiditis.
Why? Okay, endelea.
Now for the nodular thyroid disease, usually presents as small thyroid nodules. They can be normal in pregnancy, but no studies suggest that in around 12 to 43% of cases, these nodules can have a malignant transformation. And diagnosis is usually done mainly by ultrasound or fine needle aspiration cytology. So when you do a fine needle aspiration, you usually do an FNA if the nodules are more than 1 centimeter, or if the nodules there are from 5 millimeters to 1 centimeter, with a suspicious or high risk history. But now for now, you can do surgery when we have the nodules being large, aggressive, and rapid growing cancers, and with distant mates. Usually, it's usually safer in second trimester. And usually if nodules are detected in the third trimester, you usually do surgery after delivery. And you can also do the radioiodine therapy at least 4 weeks after cessation of breastfeeding. And the lady is asked not to conceive for 6 months to a year. So now for the Sheehan syndrome, usually it's a pituitary necrosis secondary to ischemia within hours of the delivery, usually secondary to hypotension and shock following obstetric hemorrhage. And the hypotension and tachycardia usually persists even with the adequate blood replenishment. And you can also have failing in lactation. You can also have hypoglycemia coming in. So now for the delayed symptoms, we have loss of libido, amenorrhea, breast atrophy. And usually we have 2 forms. We have now the acute form and the chronic form of the Sheehan syndrome. So for the acute form, it can present with hypotension, tachycardia, failure to lactate, hypoglycemia, failure to regrow shaved pubic hair, extreme fatigue, nausea and vomiting. But now for the chronic one, usually presents with fatigue, lightheadedness, persistent amenorrhea, decreased body air, dry skin, loss of libido, nausea and vomiting, and cold intolerance. So now when you do an MRI, usually you see partial or completely empty villi because of the necrosis of the pituitary gland, and replacement therapy is the only option of treatment. And it is usually usually very rare when we have a good obstetric practice. Thank you.
Did you read about congenital hypothyroidism?
No.
Do you want to say something about it? Should the neonates born from women with either of these thyroid conditions be screened?
It was formerly called cretinism, and usually it's we have the severe deficiency of the thyroid hormone in newborns, and usually causes impaired neurological function, stunted growth, physical deformities. Yeah. So the most common cause it's usually unknown, I think, not so sure though.
For developmental disorders where you have either a genesis of the thyroid or hypoplasia of the thyroid.
Okay.
Then usually in good countries, all children are usually screened because of the adverse effects that you've talked about on neurodevelopment of the newborn into later life. So the question is, do you need the thyroid to live or not? Is it essential for life? Can you live without the thyroid gland?
No. I think yes.
You can live without it. Yes or no? Can we live without it or not?
I think if you take medication, yes.
For replacement.
So it is important in life, but not essential. You will not die from. But the only problem is you'll have this severe growth problems and neurodevelopment issues with the child,
Okay.
and obviously metabolic problems. So does someone want to try the questions I had asked? We can begin with what the recommended daily intake of iodine in pregnancy.
To 20 to 9.
Yeah, or you will check.
220 to 290 micrograms per day.
Okay. The other question, anyone wants to try answer that? So can someone summarize what are the physiological thyroid changes that occur in pregnancy? Because that's a critical take-home message from this presentation. Let me pick someone. Isaac Nyaga.
Okay, I'm not sure.
Anyone?
So about the physiological changes or adaptations of the thyroid in pregnancy, the presenter talked about TBG increasing almost twofolds due to the increased estrogen levels. He also mentioned that the HCG, which lead to increased thyroid functions, are also elevated in pregnancy, a common physiological process. Then he mentioned also the iodine requirements, which I think slightly are increased in pregnancy to around 220 to 290 micrograms per day. I picked those three.
So does the free hormone get affected in pregnancy or not? Or is the total hormone that gets affected in pregnancy? Okay, you'll all take note of that. Then the other question, which I think the presenter looked at, are the effects of lack of the thyroid hormones or in excess of it on the body. So the effects begin from the head to the toe. I think the presenter missed out on some of the changes you see from the hair to the other systems. So it's critical. Every patient you see at every visit, whether on treatment or not, should be evaluated for these symptoms. So allow me to ask, what are the menstrual changes that you will see in a woman with hyper and one with hypo? Or the menstrual pattern does not change. Let me pick someone. Farida. Okay, you all don't want to talk. We carry on. So I think we have reiterated we have overt hypothyroidism and subclinical hyperthyroidism. It's the same for the hypo. There is overt and there is subclinical. You need to know what the differences between the two are, what are the commonest causes, and the mechanism with which these causes result in hyper or hypo. Particularly of importance is to know what happens to the fetus, the neonatal effects of hyperthyroidism to the fetus, and also the neonatal effects of hypothyroidism on the neonate, actually, not the fetus, the neonate. Then I think you discussed well about teratoxicosis, but some of the precipitants of a thyroid storm can be from anemia, trauma, and such. So you need a very high index of suspicion. It is an acute, life-threatening emergency. And I think Dr. highlighted very well. It is ideally managed in an ICU setting. And remember, you have to start the patient on PTU, thioamine. And the dose is actually higher than the normal dose you give. You can even go up to 1,000 milligrams as a loading dose. If the patient is not able to feed, you give it as through an NGT tube. Then remember, propranolol is also critical in terms of rate control. And the other drugs we talked about, the iodide, as well as the role of steroids, dexamethasone or hydrocortisone. Are we okay on that?
Yes, Doctor.
So the other question is, should we screen all women for thyroid abnormalities? This is for the presenter.
Do you have it on you? I thought you'd always, walk around with some.
I always do.
Should women be screened for hypothyroidism? All women? Okay, we'll take that as well. Then remember, for subclinical, either hyper or hypo, there's no need for treatment, and generally there is no adverse effect on pregnancy. That's why you need to treat, and that's why you need to know the clinical difference between subclinical and the overt kind. Remember, for the overt kind, the mainstay of treatment is the thioamide, as the presenter had talked about. But the cutoff is that methimazole is a drug that is teratogenic, so to say. So it's commonly avoided in the first trimester. Any questions? Then the other thing which I think the presenter didn't highlight is what's the difference in the mechanism of action of the two drugs, and why you would not give methimazole for a patient with thyroid storm. There is a difference in terms of that propylthiouracil PTU has an additional effect of inhibiting that peripheral conversion of T4 to T3 that you had talked about in your first or second slide. Yeah. Any questions?
I have a question. During the presentation, we said methimazole is the drug of choice in patients with hyperthyroidism. And according to its side effects, I saw it has very many side effects. So why do we still prefer it to propylthiouracil?
Does the presenter want to answer that? Frederick, is it Frederick? Why is methimazole often quite preferred as opposed to?
What I saw is that PTU is usually preferred during the first trimester, and then now for the second and third trimesters is where methimazole is much more preferred than PTU. So for the reasons, I'm not sure.
So methimazole is actually more potent than PTU. It is actually about 10 times more potent than the PTU. That's why it's routinely preferred. But the cutoff in pregnancy is that you have a fetus, so you commonly do not, you would want to avoid it in the first trimester. And I think you talked about some of the congenital problems that can arise. And that is the reason. But remember, PTU, the only common effect that you see is hepatotoxicity, and it's usually a kind of fulminant kind of hepatic failure. So you need to be really, really careful. You need to be really careful with that. If you go reach further, you'll find that there are women who have even needed liver transplant from PTU-associated hepatotoxicity. So you need to monitor these women actually quite keenly when they are on PTU. So what's the difference between methimazole and carbimazole? Which is which? So go find out which is the prodrug.
Is it methimazole?
Carbimazole is the
Any other question? Any other question? Then the other thing maybe I may have forgotten is you need to understand the physiology of how the thyroid hormone results, because there is from where the treatment usually comes in. Then you need to understand what the thyroid receptor antibodies in Graves' disease he was talking about, and how disease arises in Graves. Then you also spoke of thyroid peroxidase antibodies in Hashimoto's thyroiditis. So you need to know what exactly happens in Hashimoto's thyroiditis, that you have hypo instead of hyperthyroidism. And the final question to close the day: are there women with these antibodies that have normal hormonal thyroid hormonal function? Frederick.
Yes.
So I think you had said one of your slides, so you can't have normal hormonal levels but presence of these antibodies for one reason, no, or the other. So routine screening is also not recommended for these antibodies. Similarly, routine screening for women for thyroid disease is not recommended routine. It has to be actually risk-based kind of screening. And remember, monitoring of treatment is done every 3 to 4 weeks on average for either of the hypo or hyperthyroidism. And I think with that we can, unless there is any other question. Okay, please, you can go to the class.
Okay, thank you. Thank you for facilitating the class. And I think if there are no more questions, everybody is free to leave and have a good evening.
Okay, all the best.
Thank you.